Welcome everyone. Thank you for being here today. We are going to have seizure medications and side effects webinar today. And a few housekeeping notes. This webinar is an hour in length. Due to bandwidth capability, we recommend closing out other applications that you are not using. You'll receive a certificate of attendance for today's webinar, and this is being recorded. If you have any questions, you can use the Q&A feature to type in your questions. We'll have a Q&A session at the end, and so feel free to be thinking of those questions throughout the webinar, and we'll address those at that time. And today's presenter is Alexandra Sakura. She is a doctor and epileptologist, and you can see that she has a lot of credentials, and we're so grateful for her expertise and willingness to come and share with us today on this topic. And so we are going to start with our first poll question at this time to get a feel for who is here. And so at this time, you'll see your poll question. And the first one is, what is your relationship to epilepsy? And there are options. If you have more than one connection to epilepsy, it's multiple choice. So you are able to select more than one option. So go ahead and complete that. Looks like almost everyone has completed it, so we're just going to wait just a moment. All right, and it looks like everyone has completed it at this time, so we'll go ahead and we'll look at the results and we'll see. And it looks like we have about 2/3 of people work with someone who has epilepsy, work with people who have epilepsy, and 1/3 of the people attending today have a family member that has epilepsy. And so we have a mixture of people here today with different relationships to epilepsy. Thanks for sharing that with us. All right, so we can close that out. Before we get started, I want to share today's objectives. Today, our hope is that you will leave here with increased knowledge of available epilepsy medications. You'll have improved insight of common side effects of seizure medications. You'll have gained understanding between medications for daily use versus rescue medication, and you'll have attained awareness of the importance of medication adherence. So at this time, I'm going to pass it off to Dr. Sakura and let her share with you. And I'm going to ask, oh, Dr. Sakura, you are still muted, so you'll want to go ahead and unmute yourself.
All right. Can you hear me now?
I can, yes.
Okay, great. So thank you so much for inviting me to speak on one of my favorite topics, so seizure medications and potential side effects. And we're going to review a lot today. And as mentioned, happy to answer any questions at the end. So first, I think it's important that we all have a common language when we're discussing seizures. And starting out, it's important to know the difference between seizure and epilepsy. So what is epilepsy is sort of a good starting place. So the definition of epilepsy is a neurological condition, and it's really characterized by unprovoked recurrent seizures. So there's a couple key words here, and one is unprovoked, okay? So there's a big difference between an event that's provoked, for example, from severe sleep deprivation, from a new medication, which is known to lower seizure threshold, from potential electrolyte abnormalities, for example, high or low blood sugar or low sodium, so, you know, as an epileptologist or a neurologist in general, really, whenever we see someone for seizures, we're trying to figure out, are these episodes unprovoked or provoked? And then the other thing here is recurrent. So again, this isn't necessarily an isolated lifetime event. There is a tendency with epilepsy to have recurrent seizures. So it may be called seizure disorder or condition as well. And here, okay, that's fine. So what is a seizure? So seizures are sudden and they involve brief, uncontrolled electrical activity in the brain. So we think of these as abnormally excess synchronous activity, meaning that brain areas are operating in an abnormally synchronous way and a hyper excitable way. So there's increased activity. So some neurological conditions are characterized by decreased activity, for example, an ischemic stroke, whereas seizures is an increased electrical activity. And seizures can occur with other conditions. So for example, diabetes, seizures can definitely be a manifestation of poor glucose control. And they can be displayed in different ways depending on the area of the brain involved. So one person's seizure might look very different to another individual's seizure. So if a seizure starts in the frontal lobe, there might be speech deficit, for example, because some of the language centers are in the frontal lobe, or there might be abnormal movements on one side of the body, whereas the parietal lobe, which has a lot of the sensory functions, might actually just be this painful tingling in one side of the body. Occipital lobe could be visual symptoms. Temporal lobe, which is the most common area in the brain to have seizures, can manifest in a lot of different ways, can have autonomic symptoms, change in heart rate, sweating, that sort of stuff. And there's a lot of memory centers as well. So you can have sensation of sort of time slowing down, deja vu, that sort of stuff as well. So again, every seizure can be very different. And sometimes they can be pretty, what we would say, bland, meaning that not everyone, or potentially not anyone, would pick it up, and the individual might be the only one knowing that they're experiencing a seizure. So in general, what we think of as seizures, the general public, are really the generalized tonic-clonic seizures, and that is often when individuals are brought to medical attention is after a generalized tonic-clonic seizure. When in fact, if as an epileptologist or a neurologist, or if family members, co-workers, or individuals living with seizures or epilepsy, there may be several different smaller events that have occurred in the past, and it's our job to kind of unravel those. So there are several known potential seizure triggers, and again, when we are meeting an individual with seizures or epilepsy, we always try and figure out what are the potential triggers and whether or not we can eliminate these. So some of the most common missed or late medication. So medication non-adherence or missing medications is certainly one of the most common triggers for seizures. Stress, anxiety are other really commonly reported triggers. Lack of sleep, sleep deprivation, fatigue. So often, sort of a classic example of this is someone going off to college and preparing for their exams and having a lot of stress with performance and doing well on the exams, and then also coupled with sleep deprivation. That might be that perfect storm for their first lifetime seizure. Hormonal changes, so something we refer to as catamenial epilepsy, when seizures tend to cluster around a female's menstrual cycle. Alcohol certainly can reduce the seizure threshold, not only when intoxicated, but in particular when withdrawing or from alcohol in individuals who are heavy drinkers, daily drinkers, or recreational drugs. So some drugs are definitely known to lower the seizure threshold. Drug interactions can also trigger seizures. Overheating and dehydration, poor diet and missed meals, and then photosensitivity. So some seizures are known to be photosensitive, meaning looking at lights, flashing lights can absolutely trigger a seizure. So sometimes during a routine EEG, often we have that photic stimulation with the lights flashing at different frequencies, and that can trigger a seizure in some individuals. Sometimes people also mention that when they're driving and they're looking at trees and they see kind of those lights coming in between the trees, that can really be irritating and can cause a seizure. So that's not an exhaustive list. There's a long list of potential triggers, and every individual is different, but those are some of the common ones. So treatment options in epilepsy. One of the most exciting things about the field of epilepsy is how many treatments we have to offer. So medications are absolutely first line, and we will be focusing on them for today. There are several different anti-seizure medications, and a lot with different mechanisms of action. And in most individuals with seizures with epilepsy respond to anti-seizure medication. However, for individuals who are deemed to be refractory or unresponsive to medications, there is the option of referral to an epilepsy center for discussion of brain surgery, implanted devices such as VNS, vagal nerve stimulation, or RNS, responsive neurostimulation, diet, so ketogenic diet and different variations of that, and then medical cannabis as well. So there are different treatment options, but today we're going to focus on medication, and I understand that the EFMN has organized other webinars to discuss some of the other treatment modalities in more detail. So here's another poll question.
Yep, we're going to go ahead and do that next poll question. So go ahead, I'm going to have that launched. Perfect. On a scale of 1 to 5, 5 being very knowledgeable about side effects of seizure medication, how would you rate your level of knowledge? So 5 being very knowledgeable and 1 being the least. We just want to get a gauge for how comfortable you feel at the start, and then we'll ask you the same question at the end. We'll hopefully see some changes in how you feel about your knowledge of side effects and medication. So go ahead if you haven't responded yet. Okay, it looks like everybody has responded. And so we'll go ahead and we'll look at the results of that. And you can see that most people are somewhere around 2 or 3, and that's perfect. You know, that you have some knowledge, that you came here today knowing a little bit about side effects and medication. And I'm confident that by the time we are done after this webinar that you'll feel even more confident. So thank you for that. We'll go ahead and close the poll and we'll move on. All right, so thank you again, Dr. Skira, go ahead.
Okay, so medication. So as mentioned, medicine is the primary way in which seizures are controlled and is almost always the first line of therapy. So different medications help with different kinds of epilepsy and seizures. So in general, there are 2 types of epilepsy that we think of. One is focal onset epilepsy, which means that one particular area of the brain is involved at seizure onset. And with the seizure evolution, it may involve other different areas of the brain, and it may even transfer over to the other hemisphere and then even look like a generalized tonic-clonic seizure when in fact it started in a small area of the brain. That's what we call focal epilepsy. And then the other type in general is the generalized epilepsy, where both hemispheres are involved at seizure onset. And we know that some seizure medications are what we refer to as broad spectrum anti-seizure medications, which means they're good for all different types of seizures. And some are really best for focal onset epilepsy. So really when you meet with your neurologist or epilepsy provider, epileptologist, they're gonna ask you a lot of questions and also call on any witnesses, potential family members, co-workers, or just, you know, sort of random witnesses, someone in the store or something, to see whether there was any clear focality to the seizure before potentially it evolved into secondary generalization or just you know, ended as a focal seizure as well. So again, we know that different medications help with different kinds of epilepsy, and we really try and get that diagnosis right at the beginning to make sure that we're choosing a medication that is best for that type of epilepsy. As mentioned, most people are seizure-free on anti-seizure medications. So medications control seizures for about 7 in 10 people living in epilepsy. And never stop or change your medication without talking to your epilepsy team, whoever it is, whether it's a neurologist, a APP, or epileptologist. Always discuss with them before making medication changes. So medication effectiveness. So about 47% of patients find control with their first medication. And again, the key here though, is that we're choosing a medication that's appropriate for the epilepsy type. 13% of patients find control with their second medication, and only 1% of patients find control with their third medication. And side effects really differ based on the different medication and the individual. So one individual may have a certain side effect on the same dose, same medication, compared to someone else. So really we have to keep this in mind, when discussing with the particular individual. So how do medications work? How do anti-seizure medications work? So there's quite a complex pharmacology, and I just sort of wanted to say in general that seizure medications either act to reduce the brain excitation. So as I mentioned earlier, seizures is really this abnormally excessive excitation of brain activity. So one way to reduce seizures would be to decrease the brain excitation or increase the brain inhibition, so sort of try and calm down the brain. So in general, the main excitatory neurotransmitter in the brain is called glutamate. So some seizure medications try and calm down the glutamatergic system. And then the main inhibitory neurotransmitter is GABA. And so some medications try and enhance GABA and try and increase that inhibition. So this isn't an exhaustive, pharmacology review, but I just sort of want to mention these are some of the strategies to try to achieve seizure control through medications. So there's a really long list of seizure medications, which is great. That's not to say that we don't need more. We absolutely do, and there's a lot of research and development going on, and actually a couple of new medications that have recently hit the market, so that's exciting. But the EFMN has this great resource, and it really outlines some of the different seizure medications. And here, it lists the generic name and the brand name as well. So I think it's important always to know that there are two names for medications, and to be familiar with both. And then the common uses. So again, some seizure medications are best for focal seizure, some for generalized, some for all seizure types. So it's nice, the common uses, and then the possible side effects. Now, to be quite honest, the list of potential side effects is very long for every medication, not just anti-seizure medications, any medication. So when we counsel on side effects, we really discuss the most frequently reported side effects and also some of the most serious ones to be aware of. But if you're wondering after starting a medication, gosh, my eyes are just a bit sensitive to light, and I never had this before. I don't have a headache. It's just weird. Definitely talk to your epilepsy team, and we can look up whether or not that is a reported side effect. So again, we kind of focus on the most common and the most serious, but there's quite a long list of potential side effects. And again, we're always trying to figure out, A, is it a side effect from the medication? B, is it a debilitating side effect, meaning does it warrant potentially a dose reduction or a change in medication? And again, that really depends on each individual, which is why it's really important just to have honest and open discussions. So yeah, we won't go through all of these today, but I like just sort of having them up, and I think it's a great resource from the EFMN. It is available on their website, so I definitely encourage you to take a look at it. So again, just going through the different meds. So signs of rare drug reactions. So, you know, some reactions can be minor, you know, a little bit of a headache, a little bit of nausea, but there are some more severe signs and symptoms to be aware of. So rash is something that we counsel on a lot. The presence of fever or sore places in the mouth, ulcerations, easy bruising, weakness, loss of appetite, and then an increase in seizure frequency. So sort of a paradoxical increase in seizure frequency. So those are all reasons to potentially not wait even to talk to your epilepsy team, depending on the context, but you might actually want to be seen in urgent care or the emergency room. So there is a difference between generic and brand medications with respect to the name. In general, the brand name is the name that the company that brings the medication to the market uses, and then the generic name is the active ingredient. So as I mentioned, it's good to be familiar with both. In most situations, generic forms of anti-seizure medications are less expensive and are appropriate. So in general, we think of generics as being equivalent with respect to their side effect profile, their efficacy, meaning how well they control seizures. You know, in general, we do recommend it. There are some exceptions where a particular individual might just be really doing well on a brand medication and may have tried generic forms and just not responded as well, whether it be side effects or seizure control. And there are some specific situations where, you know, it might be really suggested to stick with a brand or a specific generic formulation. But in general, we think of generic and brand as being equivalent. But changes in seizures and side effects, as mentioned, can occur. So again, it's up to you to know that, and your epilepsy team to know when you're switching around either from brand to generic or even within different manufacturers within generic, and then to watch for any change in side effects or change in seizure frequency. And if anything arises, to definitely let your epilepsy team know. And I think one thing that sometimes I do, and this was passed along to me by one of my mentors, is if I'm switching from brand to generic, you know, I'll check a level when, so an anti-seizure medication level, which is a blood level. And in general, we check this before your next anti-seizure dose, medication dose. So it's what we refer to as a trough level. So it's not just right after you take the medication. We want to see how low it gets in your blood before you take the next medication to make sure it's still sort of within general acceptable therapeutic limits. And then see, you know, are you having seizure control on this dose of the brand name, for example, and brand medication? And say your level of carbamazepine was about a 6, for example. And then if you were to then switch over to generic, and you might just check, of course, for side effects or for increased seizure, but also just to make sure that that level is equivalent, you know, you might have that level checked in a couple of weeks after switching to generic. So again, every seizure doctor is different, but you know, that's one potential strategy. But again, avoid switching between formulations without the approval of a provider. And some individuals are very sensitive, so they may need to remain on a specific brand or use a consistent manufacturer. And, you know, your support system, definitely your epilepsy team, you know, the nurse and the physician and et cetera, but also your family, school nurses, that sort of stuff, should be aware if there's any change, just to monitor for any increase of seizures or side effects. So medication goals is very straightforward. The best case scenario, and always my goal, is to achieve seizure freedom, meaning no seizures, and for the particular individual to not be experiencing side effects. So really what I say is, potentially someone would say, well, how am I going to feel on the seizure medication? And sort of my answer would be, well, my hope is that you feel exactly how you feel right now, today, while taking the medication. Now, is that always possible? No. And, I think, again, that comes into play. What are the possible side effects? Are these transient side effects, meaning as you're starting the medication or increasing the dose, are they sort of rearing their head but then getting better after a few weeks, which certainly does happen in a lot of cases? Or are these debilitating side effects where it's like, listen, I'm just not able to play the violin. I love the violin. It's my passion. And I've got this tremor from the seizure medication, and it's just not worth it to me. I don't want to take it. And again, that's where you have an honest conversation with your seizure doctor to potentially discuss other options. So, but again, the medication goal is very straightforward. It's to achieve seizure freedom or achieve freedom from disabling seizures or potentially dangerous seizures. So for example, a sensory seizure, some tingling in the arm may not be as disabling as, an episode of loss of consciousness, for example. So every case is different, and we really tailor the individual, treatment to the particular individual. Sometimes a second medication is needed. If there is potentially some improvement in seizures, or if there's, just incomplete seizure control. If there seems to have been no improvement in seizures on a medication, in that situation, the particular epilepsy provider might actually just eliminate the initial seizure medication and add a new one rather than adding two together. So if there really seems to be no benefit from one particular seizure medication. And then again, it's really important to be honest and open with your provider about medication effectiveness and potential side effects, because otherwise there's no way of knowing. And of course, we know that you're the one, or the individual with seizures, epilepsy, are the ones that are experiencing this. So it's really important to be honest with yourself and honest with your team in order to be best treated. So absolutely ask questions before starting a new medication. After, sometimes people start a new medication a couple days later, they think of questions. So, I think in this day and age in medicine, with the different communication tools between the epilepsy team and the individual, there's a lot of opportunities for reflection and then to be in contact even between appointments. But some questions to consider, again, this isn't exhaustive, would be, how does this medication work, and is it different than other medications that I've tried before? How helpful has the drug been in research studies? Has there been any research studies evaluating the efficacy of the medication? And what's the likelihood that my seizures are going to get better on this medication? Does the particular way the seizure medication work mean that it may work better when given with some medications than with others? Or another way to say this would be, am I going to be at higher risk of having side effects because I'm already on a medication? So are these medications working in similar ways that I'm actually going to be a bit more prone to developing side effects because they have similar side effect profiles? Or do they work in different ways that actually, if I were to have side effects, they might be different side effects? So sort of just discussing that mechanism of action and the most commonly reported side effect profile. So that kind of goes to the next question: what are the side effects of this medication, and is there something I should be looking out for due to the fact it's added to my current medication regimen? And then what about the new anti-seizure medication with my other medications I may be on? So a lot of anti-seizure medications, in particular the older medications, have a quite complicated metabolic sort of pathway. And so a lot of them can interact with other medications, for example, antibiotics. So it might be a medication you're just on for a couple of weeks or a week, but also, say, for example, Coumadin, warfarin, or something like that. So a lot of medications can interact. And it's really important that your seizure physician and your epilepsy team be aware of what other medications you're on. And not only that, you're also your primary care doctor or your cardiologist be aware of the anti-seizure medication you're on. So there can be a lot of interactions as well. So it's good to have a clear idea. And then I always sort of mention, if you are to start a new medication, always ask, is this medication known to lower the seizure threshold? So should you be a little bit more worried that you might be at increased risk of having a seizure, say, for example, because you're starting an antibiotic or something like that, and also, whether or not there are any interactions as well. So there are some more unique patient populations. And again, I'm an adult epileptologist. So this is mostly tailored for adult epilepsy. But so one would be older adults. So older adults often take more medication. So we know that they're, not all, of course, but, they might be on more meds. So there might be an increased risk for these interactions. So again, it's a time to be really aware of potential drug interactions. Also, with increased age, your metabolism changes. And so you may need a lower dose than someone with a faster metabolism. And, and sort of their filtration and that sort of stuff can change. So there's a lot of complex changes with age, but again, I think some things are, can be more at risk for side effects and can be on other medications that can work together with anti-seizure medications that might put you at quite a high risk for side effects. So one classic example of this would be an individual on a diuretic medication or a medication that makes you urinate more, and then starts a sodium channel blocker anti-seizure medication. And some of them, for example, oxcarbazepine or trileptal, can cause low sodium. And so the combination of those two medications might make you feel really lightheaded and might drop your sodium. So things like that, where you just sort of have to discuss it together with your epilepsy team, but also your family doctor, or cardiologist, or nephrologist, etc. Women's health is also a unique population. So some things for women in particular to discuss with their provider about would be contraception. So some anti-seizure medications can affect the efficacy of oral contraceptive medications. So you always want to discuss sort of contraceptive planning and methods. And again, it's an opportunity to form a liaison between your epilepsy team, primary care, and potentially your OBGYN to discuss what's best for you. So potentially a Mirena intrauterine device might be the best option, which in general isn't as influenced by anti-seizure medications, or at least if you're taking an oral contraceptive medication, to at least be aware that some seizure medications can reduce the efficacy. So you might, not be able to rely on it. And, unplanned and planned pregnancies for sure. So if you're planning a pregnancy, we always recommend to discuss this with your epileptologist to try and get on the lowest dose of the least amount of anti-seizure medications possibly that keeps you seizure free. So ideally we have at least about a year to try and optimize the medication regimen, and then of course for folic acid and that sort of stuff. And of course this isn't always possible. So, but, pregnancy is a big topic. And the medication metabolism also changes during pregnancy. So for example, lamotrigine is known, the clearance increases a lot during pregnancy. So sometimes, we actually recommend monitoring the level every month, potentially or every trimester to make sure that even on the same dose of lamotrigine that your level's still therapeutic. And then breastfeeding, so anti-seizure medications in general, most of them are excreted in breast milk. So again, always weighing risk benefits and potentially, if possible, trying to get the female on the safest medication, anti-seizure medication. So some are absolutely known to be potentially more harmful than others, and that's not always possible, but again, that's the goal. And then the lowest dose and the least number. So we know that being on one seizure medication versus being on several has a lower risk of potential harm. And then hormones and epilepsy, polycystic ovarian syndrome, folic acid we recommend in females of childbearing age, and bone health. So some seizure medications, in particular what we think of as enzyme inducers, so the phenytoin, dilantin, phenobarbital, oxcarbazepine, trileptal, and tegretol, carbamazepine, et cetera, can sort of interfere with bone metabolism and can make bones weak. So we always check vitamin D and make sure that we're staying ahead of the curve by supplementing calcium, vitamin D in individuals that are taking these medications. And that's not unique to females, it's for males as well. So what to know about taking anti-seizure medications? Well, there's a lot, but a couple of things. Make sure the doctor and the pharmacist know about any other drugs that you're taking or that the person is taking. So take the medication at the same time each day. So I always recommend having a pill box and maybe even potentially one at home and one in your purse or your weekend bag. And then having a cell phone alarm so that, say 8 a.m. and 8 p.m. are the good times for you, that your cell phone alarm goes off and you're just like, okay, time to take my medication. Again, just to try and reduce any risk of missing medications, which as mentioned earlier, is one of the most common reason for breakthrough seizures. So if you think a seizure is about to happen, in general, it's not going to help to take an extra pill. There are seizure rescue plans, which we'll discuss in a little bit, sort of in general, but I think that there is a separate webinar in a couple of weeks on seizure rescue meds, which I really recommend. It's a really important topic. So I'll save sort of the details for that. And then stopping medication or not taking it correctly is the number one reason that seizures return. So, I always mention to the individuals that I care for that sometimes if you're doing really well and you're seizure free, say for 6 months or even 6 years, and you might say, God, do I really need this medication? Again, talk with your seizure epileptologist or neurologist or care provider before stopping it, because the risk, benefits, and the safety need to be assessed. And if you are felt to have epilepsy that you haven't outgrown, again, by definition, this is a predisposition to having recurrent unprovoked events. And so the risk of recurrent seizures in the setting of not taking medications can be very high. And then over-the-counter medications can be unsafe to mix with anti-seizure medications. So again, always just reach out to your epilepsy team. Also reach out to your pharmacists who are extremely knowledgeable and sort of ask, is there any interaction? Is this medication known? So really empower yourself or if you're caring for someone or working with someone for epilepsy, just that curiosity is so important, and having that knowledge is so important. So I really encourage people to be curious and to ask questions and sort of gather that knowledge to then make decisions for themselves or for their loved ones. So medication adherence, so compliance is crucial for seizure control. So again, another example would be, and I think this is, point number 4, is that if you miss medications or if you're not taking medications and then you're having recurrent seizures, again, it's an opportunity to be super honest with your epilepsy team. And there are barriers to medication adherence. For example, cost. You know, another would be getting to the pharmacy. So, you know, I'm having seizures, I'm not able to drive right now, I can't get to the pharmacy. Or potentially forgetfulness, or, you know, there can be a lot of different reasons for non-adherence. But again, it's always best to be super honest with your team, because if your team is under the impression that you actually are taking the medication, then sort of natural next step to do in a lot of situations if an individual is still having seizures would be to increase the medication. And then if you are missing meds and then all of a sudden go from, say, 100 milligrams twice daily of lamotrigine, and your seizure team has been increasing the dose because of, you know, recurrent seizures, when in fact the medication wasn't being taken consistently or appropriately, then you're really going to you know, potentially be at high risk of having side effects. So again, just being super honest about it. Patient education is really important, and this should be multifactorial, and you know, should be absolutely discussed with the provider that's prescribing the medication, but also with members of the care team. And I find pharmacy extremely knowledgeable and very valuable in this as well. And then some strategies, as I mentioned above, is keeping a seizure diary, set the alarm on the phone, texting for control, and then a pill box. So drug-resistant epilepsy, so as I mentioned earlier, most people are seizure-free on seizure medications, either 1 or 2 seizure medications, or potentially 3. There is about a third of patients with epilepsy that have what we call drug-resistant epilepsy, or also known as intractable or refractory or difficult to treat epilepsy. And the definition of this is really when someone has not been able to become and remain seizure-free after 2 adequate trials of appropriately dosed, meaning that their level is therapeutic or they're at a good dose of a medication, and appropriately chosen medication. As I mentioned earlier, the fact that the key, especially at the beginning of establishing your relationship with your epilepsy team, but sometimes it takes several visits to gain this clarity about making sure that the diagnosis is right, that the seizure type is right, that the epilepsy type is right, so that you're on an appropriate medication to that epilepsy. So, for example, if you were on a focal agent for generalized epilepsy and you're still having seizures, that wouldn't be considered refractory. In that case, being on a focal medication is not, you know, going to be offer the same chance of seizure control as a generalized broad spectrum agent. So there are some exceptions to that, but in general, that is a definition of drug-resistant epilepsy. And this is really when we think of referral to a epilepsy center. And I know Minnesota has a few, and for a complete list, please do refer to EFMN website. Another kind of component of drug-resistant epilepsy or intractable refractory epilepsy is when seizures are frequent or severe enough to interfere with the individual's quality of life. So drug-resistant epilepsy, some possible reasons for uncontrolled seizures, and I sort of mentioned a few of these earlier, but one is that the diagnosis is wrong. So maybe it's actually not seizure, maybe it's syncope, so meaning you're not getting enough blood going to your brain and the treatment is actually increasing your blood pressure. So maybe the diagnosis is wrong, or maybe they're not epileptic seizures, they're non-epileptic seizures. Maybe the treatment's wrong, as I mentioned, so maybe you're on the wrong anti-seizure medication. Triggers or lifestyle factors, so maybe even though you're on a good medication, you're still not able to stop drinking alcohol, for example, or there's still so much stress with your job, and every time you see your boss, it's just like this trigger, or other potential lifestyle factors. So again, really trying to, or maybe your sodium's low, and that could be a trigger. So, or glucose. There's so many different potential factors, but again, we always try to figure out, is there a clear provoking trigger? And if there is, are we able to modify it? Are we able to eliminate it? Because if we're not, it still might be considered more of, increased risk of having those recurrent seizures. And then, don't respond well to the best treatment options available. There can be a honeymoon period that can end. So sometimes people do really well initially on an anti-seizure medication, then sort of develop a bit of a medication tolerance. And then maybe metabolism quickly inactivates or isolates drugs, causing them to be less effective. So there's many different potential causes that we're always on the lookout for. And this in particular would be addressed not only from your seizure team, epilepsy team that might be at a small community hospital and a clinic, but absolutely if a referral is placed to an epilepsy center, that would be thought of in great detail. So status epilepticus, so the definition has changed since I was a medical student. So the definition of status epilepticus, which is a serious, potentially life-threatening neurological medical emergency, is defined as 5 minutes or more of uninterrupted seizure activity. And it may include one prolonged seizure, multiple seizures without return to baseline, and it does require immediate action to stop the seizure medication. And this should be something that you discuss with your epilepsy team and have a seizure action plan that clearly define what constitutes the seizure emergency and what the detailed emergency response plan is. So sudden unexpected death in epilepsy is something that we're talking about more and more in the epilepsy community because we know that individuals with epilepsy, and in particular with certain risk factors, have an increased risk of early death. Sorry, excuse me for 1 second. So it's about 1 in 1,000 people with epilepsy. It's higher in people with uncontrolled seizures. Sorry, my daughter just came in the room. And with epilepsy beginning at a young age, in young adults, and then having epilepsy for a long period of time, and then not taking medications regularly as prescribed, so medication non-adherence, and then having seizures at night, in particular convulsive seizures. So these are all potential risk factors. So rescue medications, as mentioned, there's going to be another webinar, which will go through things in a lot of detail, but typically it's used for seizures, clusters, or when seizures are more frequent, longer, or more severe, so generalized tonic-clonic seizures, or those types of things. They're taken as needed to prevent a seizure emergency from occurring, but they're not used instead of or in replacement of a maintenance medication. So oftentimes, individuals with more severe epilepsy, they'll be on a maintenance daily medication and then have a backup plan if, God forbid, a seizure breaks through, what to do in that case. And they're available in different forms, rectal, buccal, and intranasal. So some of the characteristics of an ideal seizure medication would be easy to use, works quickly, of course, because you want to stop the seizure medication, and also you want to stop a second seizure from occurring, is relatively safe with little to no side effects, is in the best form to meet the particular individual's needs. So, the intranasal midazolam, for example, is felt to be a good form of a rescue medication and then works well, so it's effective. So rescue medications, so the new nasal treatments as mentioned, the midazolam, and we are using this more and more, and again, there's benefits in the ease of use and the fact that not the individual can use it and other individuals can administer it as well. Again, there's always potential side effects, and so these need to be reviewed in detail and to be monitored for. So, historically, diazepam rectal gel had been used quite a lot, and it's approved by the FDA for treatment of prolonged and clustered seizures, for use by family members and other non-medical caregivers, for example, teachers or that sort of stuff. But there's concerns with respect to privacy, ability to assess when to administer it, and then the risk of respiratory depression and sedation, which is present with any benzodiazepine, which is the class of medications that diazepam's in. So, it's always good to be aware of what's possible and what's potentially serious. But in the doses that are administered, respiratory depression is not a common side effect. But again, it's always good to be monitored for, because a particular individual might be on another medication which causes sedation or might also cause respiratory suppression, and the combination of those two medications might lead to increased risk of these potentially very severe side effects. So the midazolam is definitely one of the newest and one of the most popular options. It can be given intranasal or buccally as well in the mouth as an anticonvulsant. Again, common side effects can be sedation, muscle relaxation, and other adverse reactions can include agitation, involuntary movements, hyperreactivity, or hyperactivity and rage and aggression. So when to refer to an epileptologist? So again, an epileptologist is someone who has done training in neurology, so has done a residency in neurology for 1 year of internal medicine and then 3 years of neurology training, and then decides to go on to do either 1 to 2 years of epilepsy, which is a fellowship. So it's specialized training in seizures. And so some of the reasons to refer to an epileptologist would be failure of 2 or more appropriate trials of seizure medication. So again, when that's deemed, the epilepsy is deemed to be refractory. For uncontrolled seizures, just can't quite get a handle on them, and status epilepticus, so when you're really having severe, long, potentially life-threatening seizures. Difficult to diagnose events, so maybe potentially it's just not typical for epilepsy and you're not quite sure. One example of this would potentially be frontal lobe epilepsy. So sometimes the epileptic foci, or the start of the seizure, the area of the brain that's abnormal, would be really deep, and so it's really hard to capture it on EEG. So you might just be like, there's something going on. They're what we call stereotyped. Each event is similar. They're transient. They're paroxysmal. They start, they stop, but I just can't get a good handle on it. This might be an example to refer to an epileptologist and potentially, an epilepsy center. For significant mood, anxiety disturbances, changes in their quality of life, major memory learning deficits, sudden change in seizure type, and then signs of medication side effect, or potentially intolerance. And there's a lot of other reasons potentially too, but those are some of them. So another poll question.
Yeah, so we'll go ahead and we'll do a poll question again. So if you at this time would go ahead and take a look at that. And again, it's the same question that we asked you in the beginning. On a scale of 1 to 5, 5 being very knowledgeable about side effects of seizure medication, how would you rate your level of knowledge now? And so go ahead and answer that question again. It'll give us a little bit of an idea of how you are feeling about your knowledge after having this information shared with you today. So you have a little bit more time. It looks like we're waiting for a couple others to still respond. So go ahead. Okay, at this time, it looks like everyone has responded. So we'll go ahead and we will share the results of that. And so wonderful. It looks like everybody is now either a 3 or a 4, and earlier everybody was around 2 or 3. So I'm really happy to see that people have an increased sense of confidence in their awareness now of seizure medication and side effects. That is great to hear. And so at this time, we're going to transition to some Q&A time. And as I mentioned earlier, you have the capability of typing in your questions. And so if you would take a moment, and if you haven't already, if you would just take a look at that option, and we'll give you a moment to think about questions that you might have, and then we'll read them, and then Dr. Sakura will share her insights with us. So I'm gonna give everyone a moment here, and all right. And Mary, I'm not seeing that bar on the top of my screen right now to see the Q&A. So if you want to maybe help me troubleshoot that, I have my coworker Mary working with me right now, and I'm not seeing your Q&A. There it is. Okay. For a moment, it wouldn't show up. So now I'm going to be able to click on it, it looks like. Okay. So again, the chat part is disabled, but you do have Q&A where you can type in your questions. And so I'll give everyone just a moment here, and then we'll go ahead. All right, so I do have a question for you, Dr. Sakura, and the first one is, can you tell us again a little bit about how people can differentiate between brand name and generic? Sometimes people are nervous about switching to a generic. What's something that they should know if they're considering switching brand name to generic?
Yeah, I think in general that most people are going to get the same effect with respect to the side effect profile and the seizure control that they have on the brand name. Really the difference is when the medication comes to the market, somebody has to do some safety trials, large medical trials, which cost a lot of money. And so the company has to pay that up front and then get, is able to have the brand for, I think, up to 10 years or something before it goes generic. And so in general, that medication is a little bit more expensive. It's kind of a more, fancy name that's a little bit easier to say for marketing purposes, for example. And then after a certain amount of time, then other companies can start creating the medication and it can go generic. And so really the medication with respect to the active ingredient should be the same, and in general should be within the same kind of concentration and dose and stuff like that. The medication might look different. So an individual might actually call up my office and say, listen, I think there's been a different formulation, different manufacturer, because the medications don't look the same. So often it'll be actually the individual. But in general, we feel like the efficacy should be the same. Now, there are exceptions to this, and this is, again, a time just to be super honest, to pay really close attention to with respect to the side effect profile and the potential seizure control. And if it's felt that the individual is particularly doing well on one particular formulation or brand versus generic, that might be a time to really fight for it. But in general, they're felt to be equivalent.
All right, thank you. Another question we have for you is, if someone has good seizure control, but the side effects are not great, should they stay on that medication because it's working and just put up with side effects that aren't working for them?
Yeah, so I think this is really individualized. I think all providers pay a lot of attention to side effect profile, and what's disabling to one individual, it may not be to someone else. So someone might say, listen, I actually stay up late, so when I take my lamotrigine, I get a little bit of insomnia, but it actually works really well for me, and then I totally crash. And whereas another one might be like, listen, I need to go to sleep at 8 o'clock in order to function the next day. This lamotrigine's not working. Or as I mentioned, someone who's a painter or a musician, a tremor may not be tolerable. To someone else, it might be more tolerable. Again, our goal would be to have no side effects at all. And sometimes that is possible, but it's not always the case, and depending on the severity of the epilepsy and that sort of stuff. So the common goal is seizure control, complete seizure control without having any side effects. But, if there are going to be side effects, then we need to make sure that they're not disabling, that they're not, interfering with someone's ability to perform the activities that bring them joy and their quality of life. and potentially a minor dose reduction, might be the solution. So really everyone's different, but as mentioned earlier, just have honest discussions with your team as opposed to playing with the medications yourself.
Thanks. And we have a question that just came in, and it says, we started a new medication, Zonsemoid, if I'm saying that right, this past month, and we had a lot of bruises. This was not listed as a side effect, but we saw from your list that bruising could be an issue. We are curious, but to our knowledge, we haven't hit it ourselves. So could the bruises come from something such as touching? So could you address that question regarding bruising?
So zonisamide, also known as Zonegran, is a really good seizure medication. Based on my knowledge, it can cause some changes in your blood counts, so the number of platelets and number of red blood cells and that sort of stuff. And I believe, again, I don't have a list of all the potential side effects, but I think that bruising would be one potential side effect. So I would recommend reaching out to the prescriber and the team as early as tomorrow. And, it might be a combination of easy bruising due to contact in an individual that normally wouldn't be so susceptible. So I absolutely would take that seriously and reach out to the particular physician or provider who's prescribing the medication, make them aware and ask for their advice. If there's any easy bleeding from, gums or other things, those might be more reasons to seek more emergent care. But I definitely think it is potentially from the zonisamide, although other possible causes will likely be explored, and that you should discuss that with the prescribing team. Thanks for that question.
Yeah, well, thank you for answering those. I appreciate it. And I just wanted to, we're actually up on our hour. Otherwise, we would love to continue asking you great questions. I know you are a wealth of knowledge, and we appreciate it. So I want to mention that the Epilepsy Foundation in Minnesota does have free information and referral services. So we provide free one-on-one support, customized tools and resources, a variety of epilepsy-related topics, and material requests. So you can reach out to the EFMN anytime through our website, and there's the information for our senior coordinator, Debbie Leone. And then other things to know about EFMN, our mission statement is listed here, that we lead the fight to overcome the challenges of living with epilepsy and to accelerate therapies to stop seizures, find cures, and save lives. And our contact information is listed there and how to make a donation. References for today's training are listed in here as well. And then with that, I want to just take a moment and just thank you again, Dr. Sakura, for sharing your time and your expertise with us. It is so appreciated to have you share with us tonight. I know that it's a busy time of day with families, and we love getting to see your little one tonight too. So thank you. That added a little bit of humor to our night. And I think we can all agree that life is what it is. And I had kids behind me in the background making a little noise too. I had muted myself and was hoping that maybe nobody was hearing my little one. So thank you. We appreciate your realness and for speaking to just the many ways that epilepsy can impact people with medications and side effects. And so yeah, we are really just so thankful that you were able to be with us here tonight.
Well, thank you so much for having me, and thank you for humoring me with my daughter's little cameo appearance. And thank you all for your time. And if any other questions, concerns arise, feel free to reach out to EFMN, and they can triage your questions. But all the very best, and thank you for your time and attention.